we will understand what is sexual disorders and how the psyche is connected to it. So, sexuality is determined by various factors like anatomy, physiology of the body, relationships between the couples, past experiences, perception of being male or female, which is known as gender identity. To the average person, sexual attraction to another person and the passion and love that follow are deeply associated with feelings of intimate happiness is sexuality. So various factors are involved in psychosexuality. Psychosexuality is not confined to the physical coitus or intercourse. It is present outside the bed also. So along with anatomy, physiology, experiences of person, the related culture is also important in psychosexuality. Some cultures are more open, some are constricted. Relationships between the couples. So psyche plus sexuality is not equal to intercourse or coitus. Now we will learn about the normality of psychosexual issues. There are few points. This is anatomical basis of psychosexuality. We all know, we have learned in our anatomy classes and physiology classes. So we are not going in deep into that. So this is one of the aspects, anatomy and physiology. This is the interesting anatomical part, which is more discussed among the psychosexual issues is G-spot. So it was described in 1950 by Grafenberg, the area which is present in anterior wall of vagina and which is proximate to the urethra. Some points about G spots are it becomes engorged during sexual stimulation. It has been described like that. Many females report it's a highly pleasurable area, and the person who discovered this believed that the tissue here was analogous to the prostate and might account for the spurt of fluid. He was not sure, and he considered it to similar to the male ejaculation. Some females state that a vaginal orgasm is different experience for them, providing different sensation than clitoral stimulation. The clitoris, which is known for highly sensitive part, so some female recognize that vaginal stimulation is more pleasurable. So one explanation is that the pleasure is enhanced by the sense of closeness engendered by the coitus in penetrative sex uh, while the couples are having sexual activity. The closeness in penetrative sex happens when in this position. Another hypothesis is that these women climax in response to coital stimulation of G-spot. One is closeness, another is the stimulation of G-spot. Now the physiological response, these are the different physiological response of male and female sexual cycle. The first one is for female. There is an excitement phase, then there is plateau, multiple orgasms can occur and followed by the phase of resolution. The total duration may vary for different females. For males, more or less similar pattern is followed. There is phase of excitement, plateau, orgasm. Then there is a refractory period which is not found in females. Then patient can have another session of sexual activity after the refractory period is over. And this refractory period is varied among one male to another male. So the important thing is in this lecture is psychosexual issues, sexual learning and sexual behavior. We will learn more about the behavior of the person in regard to the sex. By explanation, normal sexual behavior brings pleasure to oneself and one's partner and involves stimulation of primary sex organs, and it is devoid of inappropriate feeling of guilt or anxiety, and it is not compulsive. It is free of guilt, and sometimes sexual obsessions are there which are different from hypersexuality. Person have imagery and thoughts of sexual activity, and to relieve that tension he used to indulge in more sexual sessions or masturbation. So it should be devoid of compulsion. Societal understanding of what defines normal sexual behavior is inconstant and varies from era to era. So sexual practices as a whole in the society is different from era to era. Like we have some other understanding in 90s or 80s, 19th century or 18th century, and now we have different understanding and different practices in 21st century. We are like more open uh, than the previous period. So the second line is the term psychosexual applies to more than sexual feelings and behavior, and it is not synonymous with libido in the broad Freudian concept. Freud gave the concept of libido, and the psychosexual term is uh, contrary to the concept of Freud's sense of libido. So here are the few points uh, related to psychosexual issues in infancy and childhood. The psychosexuality goes with at every age, at every stage of life, and it is not confined to certain age group. For say for the fertile period or adulthood, it starts from the beginning, and there is a determinant which is known as sexual identity, which already start at the point of conception, when the sex is determined by genomic compositions like XX or XY. So it starts with conception, but for the infancy and childhood, it has been observed that genital self-stimulation is normal activity of the babies. It is particularly pronounced between the age of 15 and 19 months. And for the sake of knowledge, it's a part of the general interest of children in their bodies. As they used to explore other parts of body like mouth, ears, and eyes, and different objects in the surrounding, they take an interest to explore that, and this is one of the part of it. And they found it pleasurable, then this activity can be enhanced or reinforced. Children also learn by watching the interaction of their parents. They observe demonstration of physical affection between the parents, and they are sensitive to the sexual undertone of like flirtation, bantering, and seductive interchange of the parents. They also used to learn from that. Sexual learning in childhood is adversely affected by exploitative, abusive adults. Incestuous activity with or without penetration or sexual abuse by other adults is damaging to the child. So bad childhood experience in this aspect may result into a psychosexual disorder in adult life. It may precipitate sexual dysfunction in adult life. It may produce delinquent activities. He may divert from the normalcy of life and acquire eccentric behavior which may be delinquent or may further result into criminal activities. So another points are some children are inappropriately stimulated sort of outright incest or genital fondling. Sometimes parents or adults elders do not have the intent to abuse the child, but they, in the sense of joking or some funny interest, they used to may use may cause fondling of the genital area. So they are the objects of extremely seductive parents termed eroticized children, and they frequently becomes sexually precocious. If such activities is being done uh, for them, then they become earlier known to all these aspects, which are psychosexual issues. Children who view the primal scene, the term Freud used to describe a child seeing sex between the parents, may be traumatized. This is particularly the case if they interpret coital sound and movement as physical aggression between the parents. Now, adolescence, this is the period of extreme turmoil when upsurge of sex hormones is there, secondary sexual characters are developed. Uh, Maybe the full knowledge is not known to the adolescent about the psychosexual issues, so he may remain in the dilemma, and masturbation may starts here. Caressing, kissing with partners, sexual play may start here. One's body image becomes more definite in this age. A sense of sexual adequacy and desirability begins to develop. Another thing is peer acceptance by the same sex and by the opposite sex is of paramount importance. They take it as a egoistic thing. Engaging in sexual talks and jokes, kissing, stimulating genitalia, experimenting with degrees of nudity, experimenting with different partners or with one partner are part of process of learning about sexuality. So sexuality is about of learning. Nobody knows beforehand or by the time of first coitus, nobody knows how to do it. So it's a process of learning, and all these aspects are the part of sexual learning since childhood. So these experiences reinforces the adolescent sense of being sexually male or female. First coitus, the first coitus is a rite of passage for both sexes. The young man experiencing intercourse for the first time is vulnerable in his pride and self-esteem. If it goes right, then he may become more confident. If the things don't go right, he may have performance anxiety in further act, or he may found himself inadequate, uh, low self-confidence may be there in the future. Another point is cultural myths still perpetuate the idea that he should be able to have an erection with no or little stimulation. So idea in the young age is it's a spontaneous process and no efforts are needed to achieve the erection or to perform in the sexual activity. And he should have an easy mastery over the situation, which is not natural, even though it is an act that he has never before experienced. So problem of anxiety, performance anxiety, low self-confidence, or it may lead to depression also if the symptoms or performance is poor performance is sustained, then this may lead to depression or anxiety disorder itself. Yeah. Similarly, pressure on the woman with her first coitus reflects remaining cultural ambivalence about loss of the virginity, like uh, and despite the current era of the sexual liberty. Young women with a history of masturbation are more likely to approach intercourse with positive anticipation and confidence. This is one of the point. Studies have shown that young women are more likely to enjoy their first coitus if occurs in context of a positive emotional relationship. The relationship is positive and long term, and commitment is there, then uh, things are easy in first coitus. In adulthood, by their late 20s, 70% of men and 85% of women have formed a union, either exclusive, cohabitation, or marriage. This is the data of US, not of the India. Uh, the sexual impulses in this relationship is catalytic in forming and maintaining adult love relationship. Ideally, a mature sexual relationship encompasses the capacity for intimacy and love for one's partner. This happens in adulthood. As sexual access ceases to be problematic, more attention is focused on activities itself. When the relationship grows, the more attention is centralized to the sexual activity itself. And what happens further is interference in sexual activity because of the pursuit of career, child rearing, and other family matters and community obligations may develop later in the relationship. And nonetheless, studies reveal a much higher frequency of sexual interaction among married person than the single person. Obviously, because of the availability of the partners. The modal frequency for married person is 3 times a month, with many couples relating sexually twice a week. It depends on the person to person how frequently they are having sexual activities. So in general, a graph of sexual practices does not form a bell curve. Bell curve, we all know that it's a normal uh, curve of any kind of prevalence. So for psychosexual issues, the bell-shaped curve is not found. It is usually skewed, with many persons indulging in particular behavior, or conversely, very few people doing so. So this is the wish of a person, what kind of activity they like, they practicing, and they enjoying. So it varied a lot from person to person, couples to couple. So there are the discussions regarding gender difference in the desire and erotic stimulation. Here are the few points. Usually males have more desire than do women. In the male, the usual pattern is sexual fantasies followed by the desire, initiation of the sexual act, and precedes arousal. And motivation for having sex in females may be due to a wish to reinforce the pair bond, the need for a feeling of closeness, a way of preventing the man from straying, or a desire to please the partner. Here are these may be the different motivation of females. Also, females, particularly those in long-term relationship, may experience desire synchronously with or after the onset of arousal rather than before it. So the sequence which is followed in the usually in the male pattern is may not be found in the females. In the last, receptivity to the sex act seems to be as important a prelude to sexual behavior in women as desire. So desire and arousal may uh, happen either before or after. The sequence is somewhat not organized in the females. So explicit sexual fantasies are common to both sexes. The external stimuli for the fantasies frequently differ for men and women. Commonly, men respond sexually to visual stimuli. This is very common phenomena for excitement for men. Women reports responding sexually to romantic stories where there is a hero who loves her and uh, wants her and wants to live with her. And woman's subjective sense of arousal is not always congruent with her physiological state of arousal. Again, her sense of excitement may reflect a readiness to be aroused rather than physiological lubrication. So there is somewhat mind and body discordance in the females regarding the sequence of arousal and sense of excitement. And opposite to it, she may experience signs of arousal, including vaginal lubrication, without being aware of them or without wanting to act on them. These instances rarely occur in males. So now in middle age, what happens is the frequency of marital intercourse may decline, may devote much of his energy to his career. De-eroticization of females because of her wife mother role uh, happens at this age. Familiarity between the couple for a long time is also a uh, factor for decreased frequency. So, somewhat more the unknown, uh, more the interest is there in having sexual activity. So, in late middle stage, the biological drive decreases in the intensity. It takes the male longer to reach orgasm and has a longer refractory period, and he requires more stimulation to achieve the erection. This happens as the age increases. In this age, females may have to adjust to hormonal fluctuations of her perimenopausal years, and C2 requires more stimulation to become aroused. However, middle age is period of rising extramarital activity, and again this data from the US, the frequency of such occurrence are low, like 75% of men and 85% of females remain faithful throughout the lifetime of their marriages. So there may be high chances of having extramarital affair due to the various factors. Now, old age. Uh, in the last 2 decades, coitus has also been a part of sexual repertoire of the elderly adults. Uh, Usually, in old age, what is expected is to indulge in religious activities, to forego the moh and maya of the life. But as the sildenafil came into the picture, okay, the things are changed. Now the remedies available to enhance the sexual performance, particularly of the erectile dysfunction. So other drugs are also available like tadalafil, sildenafil, and for females, hormonally enhanced cream or hormonal pills for vaginal lubrication and to combat the vaginal atrophy are available. So uh, elderly psychosexual issues are also important nowadays, and it should be discussed with the patients in this age if they are visiting your clinics. So psychosexual issues are important and not to be hide. So as per the data, 70% of men and 20% of women over age 60 years are sexually active. Uh, the percentage of males are much higher than the females, but it is there. Expected physiological changes in men, including longer time of erection to occur, decreased turgidity and ejaculatory seepage, uh, may be the problematic phenomena during this age. And in females, again, decreased vaginal lubrication, atrophy are associated with lower estrogen levels. In older age, there are lots of medical illnesses also, chronic medical illnesses like diabetes, hypertension, and some of drug may uh, cause sexual dysfunction due to their side effects, maybe a contributory factor, or the disease itself, like cardiovascular disease, arthritis. So these disease or illnesses can hamper the adequate sexual activity in the older age. So this was about the normality of psychosexual issues in a normal heterogeneous sexual couples. For an individual, there are some factors which defined in psychosexual matter, which we are going to discuss now. So these factors are sexual identity, gender identity, sexual orientation, and sexual behavior. These factors affect personality, growth, development, and functioning. And abnormality in these four factors may lead to sexual disorder or psychosexual problems. So, what is sexual identity is sexual identity is biological identity of being male or female, which is defined by the genomic combination of XX or XY. And disturbance in this genomic combination may also result into some genetic disorder, which is reflected as development of sexual organ like XO syndrome, triple X syndrome, XYY syndrome. The gender identity is when an infant, usually at the age of 2 to 3 years, have a firm conviction that I am a male and and I am a female is gender identity. Okay, biological identity is XX and XY. Now the person recognize as per their biological allocation. And problem in this area may result into what is previously known as gender identity disorder. You also may have came through the cases of some celebrities who uh, consider themselves as of opposite sex and they go for uh, sex reassignment surgery also. So this area is gender identity. Under the gender identity, there is a gender role. Gender identity is finding himself or herself as a male or female. When they found themselves as a male or female, now they do something to express themselves as a male or female. Like person says or does to disclose himself or herself as having the status of boy or man. So there are some words in the grammar which is assigned for females, some assigned for males. When they start using that, when they start wearing such a clothes, when they start taking interest in uh, such a playful activities which are known to the uh, commonly found in the different gender. So this is gender role, and it comes by experience, explicit instructions and inculcations. When adult or other family members uh, used to use those words for their gender, they used to learn that I have to use these words for my expressions. Okay. So this is also a part of learning. Sexual orientation is described the object of a person's sexual impulses. It may be heterosexual orientation towards opposite sex, homosexual towards same sex, or it may be bisexual for both the sexes. So there are other terms also which are related to sexual orientation. We will learn in the next lecture. Now the sexual behavior is how the person is behaving, to fulfill his desire, his the receptivity, fantasies, and the pursuit of their partners, autoeroticism, and all the activities which are engaged into express and gratify the sexual need is sexual behavior. So apart from the XX and XY or gender identity, there is a third community also, which are now known as LGBTQIA plus. Our court is also discussing their issues right now. The abbreviation of LGBTQIA is lesbian, gay, bisexual, transgender, queer, intersex, asexual, and plus more. We will discuss regarding the issues of this community in the next lecture, known as LGBTQ. Now, taking the sex history, it is somewhat different from taking the history of a medical disorder. A long list of questions are there, which encompasses whole of the life or and almost whole of the aspects of uh, their uh, uh, their psychosexual issues since the beginning, since the childhood. So starting with the identifying data, you all know that there is a name, age, sex, and relationship status. We used to take whether married, separated, divorced, cohabiting, serious involvement, casual dating. These are the extra points in uh, history of psychosexual problems. Yeah. Otherwise, we used to take married, divorced, or separated. That's it. Further, current functioning, in short, dysfunctions, if these are lifelong, acquired, frequency of partnered sex, about the desire and libido in terms of per day, per week, description of sexual interaction, manner of initiation or invitation. It is either verbal or physical. The same person always invite. So these are the points which has to be covered, you know, regarding foreplay, afterplay, the sex. So it is very much in detail. I have cut it down, and after cutting down, so many questions are remains there. You can imagine how many questions are there in a sexual history. So again, past sexual history, childhood sexual activities, age of onset of puberty, sense of self as a feminine, masculine. All the questions are involved. What we have learned before in the slides, and related to those aspects, all the questions has been incorporated in the history taken regarding the marriage, honeymoon, extramarital sex, areas of conflict in marriage, about widowhood, separation, special issues like history of rape, incest, sexual abuse, physical abuse, spousal abuse. You know, all these things are important in uh, dealing with the case of psychosexual disorders. Any of the psychosexual disorder may arise from another problem of the life, or it may be in the past, in childhood, like sexual trauma. Now coming to the sexual dysfunction as defined in the ICD-10, and by definition, sexual dysfunctions refer to person's ability to participate in sexual relationship as he or she would wish. है ना? Would wish मतलब means there is no standard definition of dysfunctions. There is no standard uh, SOP for defining or assessing these uh, patients. So it depends on the wish of the patient most of the time, and we will learn about in next slides. So the core concept of diagnostic group are decreased sexual desire or arousal. These, you can see, these are the part of sexual cycle: difficulty having or timing orgasm, pain or discomfort during sex. This is the part of gender identity. Confusion about the gender identity. Now it is known as gender dysphoria, or gender incongruence in ICD-10, and gender dysphoria in DSM-5. Other problems can be of non-human use of non-human objects for sexual arousal, like paraphilias, disturbing sexual acts and fantasies, uh, encompassing the certain paraphilias, culture-bound syndromes like Dhar syndrome or Koro is there, myths and facts about the sexual problem, overtly over expectations uh, from the partner, from themselves, is also a problem. The normal phenomena they may found as an abnormal thing. So myths and facts about the psychosexual issues. Learning from pornography. This also comes under myths and facts. We will discuss in this aspect in the next lecture. And sex problems of unmarried and inexperienced males. As previously discussed, the poor performance may lead to performance anxiety, depression, anxiety disorders, low confidence, and may lead to somatic symptoms also. So these are the core concepts. Uh, Three large categories have been defined: sexual dysfunctions, paraphilias, and gender incongruence. So, in sexual dysfunctions, in broad category, there are sexual desire disorder, arousal disorder, sexual pain disorder, orgasmic disorder, and other sexual dysfunctions due to general medical conditions, substance abuse. In sexual desire disorder, hypoactive sexual desire disorder is too much or too little sexual desire, deficient or absent sexual fantasies, and desire for sexual activity can be called as low libido. So psychological cause of hypoactive sexual desire may be uh, relational problem like marital discord, fights between the couples, altercations, blaming each other, and expectations in sexual life or other life from your spouse, superiority complex in the spouse, maybe may cause sexual hypoactive sexual desire disorder. Unwanted partner. In our society, like in arranged marriages, sometimes the person is forcibly married and he or she don't want to marry them. So unwanted partner may also be a cause of hypoactive sexual desire. Aversions, like a male from puritanical background, where male dominated society is there, and being a lovable, caring person for the family is considered as a not good thing. So puritanical background may also cause hypoactivity in the sexual activity. Sense of sinful act. As we know, the females in uh, our community is grown up like that from the beginning, that sexual talk, sexual expressions, sexual activity is a sinful act. So uh, then after marriage, the same female do not come up or open with the expectations of her husband, and this may be a cause of low sexual activity. Mismatch of wishes may be there. The frequency of both the partners are so different that another partner found him helpless in indulging in the sexual activity. So these may be the cause. So in the short, treatment is couple therapy, or it is also known as sensate focus therapy or dual sex therapy. So sexual aversion disorder, as we have discussed, extreme aversion to avoidance of all or almost all genital sexual contact with sexual partners. And one of the cause we have discussed aversion. Other causes may be sexual abuse in childhood, which may create deferment from indulging in sexual activities. Phobias, fear, and anxiety of having the experience, and again the performance anxiety can cause sexual aversion disorders. Again, in the short, couples therapy and other therapies may found useful in these disorders. Hypersexuality, previously known as nymphomania, satyriasis, and it is not the part of classification, but it is worth to know. There are four stage cycles: increased craving for sex, ritualized searching for sex, sexual behavior, period of guilt and despair. And medically, it can be found in multiple sclerosis, epilepsy, stroke, brain injury, or dementia-like situations. And you can see that all these disorders are degenerative disorders, and hypersexuality is found in them. So, if you go with the theory of topographical theory of Freud, with ego and superego, uh, you can relate to that. The inhibition is gone when there is degeneration in the brain parenchyma. So, psychological causes can be mania. Hypersexuality is the part of manic symptom. It may also found in psychosis, uh, found in history of sexual abuse or adult OCD in obsessive compulsive disorder. There may also found hypersexuality to relieve the obsessional tension, and like stress in life may also cause hypersexuality to relieve the stress or tension. So treatment is treat primary disorder, individual psychotherapy and SSRI may helpful. Now, female sexual arousal disorder symptoms are inability to attain and maintain adequate lubrication and the physiological response. It may make sex painful or unpleasant. The treatment can be use of lubricants, sex therapy like sensate focus, non-demanding pleasuring, and non-genital pleasuring. Male erectile disorder, also known as commonly impotence, which is inability to attain or maintain an adequate erection until completion of sexual activity. It may be lifelong, or it may be secondary after history of normal erections. There are four basic types: no erections, partial erection, uh, full erection lost before sex is completed. Erection occurs sometimes, but not when person wants to it. So before considering them as having psychosexual disorder with these persons, normality of erection should also be understood. Uh, for example, uh, one don't stay exactly at the same level of excitement during a session. In a sexual activity, the mental excitement doesn't uh, remain at the same level. It is fluctuating. And the sexual activity also depends on the excitement of mind. If there is fluctuation in your mind regarding the sexual excitement, there may be fluctuation in engorgement or erection of the penis also. So in this situation, don't panic. It happens. It is normal. Instead, take a break. Pleasure her to take the pressure off. Don't take the pressure or tension at the time, and calm down. Then start again, and it may be helpful to having the normal sexual activity. So when the person comes with this problem, do not rightfully consider themselves as having the problem. This may be normal also. Other contributory factor may be smoking, uh, alcohol, which can cause hypogonadism. Smoking can cause hyperlipidemia and plaque formation. So the process of erectile of having erection is through the gush of blood enters into the penis. When there are plaques, and proper erection won't happen due to the hyperlipidemia due to smoking. Obesity may be one of the cause. Other drugs like antihypertensive can also cause erectile dysfunctions. Antidepressants can also cause low level of testosterone, vascular disease, hypertension, diabetes. So these are the secondary cause of male erectile disorder should be considered in uh, when the patient is having a long history of medical disorders like diabetes. Treatment can be these are the surgical treatments. First of all, you have to go for ruling out if there is any psychological abnormality or not. If the corrective surgical procedures are required, then one can go for surgical methods. Mechanical devices are there like vacuum constrictions, which draws the blood into penis. Medications, sildenafil and tadalafil can also help. Lifestyle changes for like smoking, alcohol, obesity can be taken into account. Losing weight, quitting smoking, exercising, and relationship counseling for marital discord. Female orgasmic disorder. The symptoms are delayed or absent orgasm following normal sexual excitement. So do consider the age of the patient, sexual experience, and adequacy of sexual stimulation, that is foreplay, into the account, which may be the cause of female orgasmic disorders. Other cause can be neurological damage, antihypertensive drugs, antidepressants, tranquilizers, any physical cardiovascular problems, and the relationship crisis, which is the important part to be ruled out. The treatment is directed program of self-stimulation and increased communication between couple, uh, or the coitus in controlling position. So it is the normal data that 70% of female do not achieve orgasm by the penetrative sex. They require stimulation of clitoris, which is not uh, occur in the penetrative sex. So additional clitoral stimulation is required, which can be achieved by when the female comes into the controlling position while having sex, which is known as women and top position. Similarly, male orgasmic disorder, again take age, sexual experience and adequacy of stimulation into the account. Causes may be physical like neurological damage, peripheral neuropathy, antihypertensive drugs, antidepressant, relationship crisis, and the treatment is the same. Premature ejaculation. Yeah. So when the patient comes with this complaint, do consider the perception of prematurity in that patient. Uh, so sometimes it is his own wish to increase the time. There is no problem. He has a notion that I want to have it for 5 minutes, 10 minutes, or even they demand for half an hour. So their own wish time, and the prematurity may be the wish time of his partner, which is related to orgasm of the female partner. So may complain that I want to uh, achieve orgasm after my partner or along with my partner. So different treatment is different for these different situations. Different treatment are there. Some persons are satisfied but still wanted more. Even partner has no complaint. No dissatisfaction of both partner, but friend told that I last for half to 1 hour. So they came into a discussion with friend and overwhelmingly, he told that I used to last 1 hour, but nobody had seen that fellow also. But he claims that he lasts for half or 1 hour. Then the person gets a notion that actually I am ill. I am having the timing of 2 minutes or 3 minutes. So these notions should be corrected. So as per ICD, uh, premature ejaculation is ejaculating with minimal sexual stimulation before, upon, or shortly after penetration. So these are the situation which has to be handled uh, if the person is having ejaculation before the penetration or shortly after it. And this is the most frequent sexual dysfunction for which the person comes into the clinic. Again, take age and other factors into the account. Uh, the causes, psychological causes, may be early learning of the sexual issues. Inexperience may also be an issue. The performance anxiety and prostatitis, these can be cause of premature ejaculation. And for inexperience, the nerve endings of the person who recently became sexually active are highly sensitive. So the signal goes in the abundance to the brain, and person may ejaculate early. So this may be the problem of young adults. Dyspareunia, painful sex, persistent genital pain before, during, and after sexual intercourse. The cause may be malformation of genitals, scar from childbirth, surgery, vaginal infections, atrophy, dryness may be the cause of dyspareunia. Allergy or sensitivity to the latex or spermicide. Extreme anxiety may be the psychological cause. Clenching of pelvic floor in females because of the anxiety may be the cause of dyspareunia. Vaginismus is vaginal spasm or contraction, uh, which may be recurrent or persistent involuntary spasm of vaginal muscles that interfere with the penetrative sexual intercourse. Cause may be performance anxiety, fear of losing virginity or uh, being organ being damaged, The fear of that also, unresolving anxiety may also be the cause of vaginismus. Sexual dysfunctions can occur due to other general medical conditions like prostate surgery, trauma, neuronal damage, diabetes, hyperlipidemia. It may also induced by the chronic alcohol use or anxiolytics or abuse of other substance or drugs. So before uh, making a diagnosis, consider first the normalcy, whether the diagnosis is warranted or not, and judge what's the normal and adequate sexual potency, performance, and desire to variability among individuals. Relationship matchups is there or not, cultural norms, what are the cultural norms there in the society. Again, the age, level, experience, cultural, religious values, adequacy of sexual stimulation, these things should be taken into account before uh, giving the drugs or treatment. Determine the etiology, whether it is psychological, it is due to general medical condition, or it is due to side effect of medication or substance. This should be ruled out. So other contributing factor may be gender, age, and usually at different ages, different problems are there. Health problems like physical problems, hormonal factors, in particular in females, and use of substance may be the factor which are contributing to the psychosexual disorders. Psychiatric problems like depression, stress, anxiety, prior sexual experiences, whether that was fruitful or good or bad, should be taken into account. Life stresses, relationship problem again, lack of communication between couples, lack of affection, power struggle, conflict should be considered and may be associated with the sexual dysfunctions. Physiological test is we can go for strain gauge for monitoring penile luminescence in the night, plethysmograph or ultrasound for measuring the blood pressure in the penis. Neurological impairment may be detected by decreased vibratory perception in the penis, and other diagnostic tests for other physical problems like diabetes, glucose tolerance test, hormone assay, liver and thyroid dysfunctions, prolactin and FSH assay, and other tests as and when required. So apart from the non-psychopharmacological treatment, as we have discussed with the different disorders like psychoeducation for normalcy, psychoeducation for inexperienced or beginners, start and stop technique we will discuss in the next lecture, skills technique we will discuss further. Barrier method for PME can also be tried. If the nerve endings are very sensitive, the barrier method can reduce the sensitivity of nerve endings. Controlling position we have discussed for female orgasmic disorder, CBT, psychodynamic therapy, relationship counseling are there. And apart from that, certain drugs can be used for sexual disorder like for desire, decreased desire, bupropion or cyproheptadine are known to enhance the sexual desire. For PME, premature ejaculation, fluoxetine, depoxetine, lignocane spray can be tried, and anti-anxiety for performance anxiety. Yeah. So this was about the sexual dysfunctions, and now we come to the gender identity disorder, which is also known as transsexualism. And this is one of the factor, psychosexual factor. We have learned that there are sexual identity, gender identity, sexual behavior, sexual orientation. So one part is gender identity, now known as gender incongruence in ICD-11. So the quality is repeated stated desire to be or insistence that one is of the opposite sex. Preference for cross-dressing, insistence on wearing clothing stereotypical for the other sex, strong persistent preference for cross-sex roles, persistent fantasies of being the other sex. These wanting may warrant the diagnosis of gender identity disorder. So ICD-10 had gender identity disorder in children, GID in adolescent or adults. These were included in the ICD-10, and in ICD-11 there is gender incongruence of adolescents or adulthood. More or less theme is same, the wanting or behaving for being of opposite sex, or wish to be converted, physically converted into opposite sex. This is gender incongruence of childhood. Similarly, some differences in presentation other than adulthood, gender dysphoria are there in childhood, but the theme remains the same. The thing which is important is the incongruence must have persisted for 2 years. uh, Gender variant behavior and preferences alone are not basis for assigning the diagnosis. So treatment planning for gender incongruence may be modifying the identity to fit biological sex if it is possible. And if it is not possible, then one's body to align with one's gender identification, which is known as sex reassignment surgery. Sex reassignment surgery requires some prerequisites like psychological, physical evolution, and their real life experience living as opposite sex for at least for 1 to 2 years. If they found fit in living with that uh, sexual identity, gender identity, then they may go for hormone treatments for before the surgery, and then surgery to reconstruct genitals and follow evaluations. So this is about the gender identity. Now I'm closing this lecture, and we have learned about the normality of psychosexuality, the factors of psychosexualities of individual sexual disorders, and the last is gender identity disorder or gender incongruence. So thank you, and in further lecture we will discuss about the paraphilias. Psychosexual issues are a very vast topic. We will discuss paraphilias, culture-bound syndromes, myths and facts, psychosexual aspect of pornography, and problems of unmarried and uh, unmarried males. And these some techniques and details like squeeze technique, start and stop method for premature ejaculations, Kegel exercise for premature ejaculations, and sensate focus therapy, which is found to be fit for most of the psychosexual disorders. This is also called as dual sex therapy or couples therapy. In further, we will learn this thing.